we're going to hear about syncope and out-of-hospital cardiac arrest, and we're going to have Dr. Win Shen, who is the chair of cardiology at Mayo Clinic, Arizona. Used to be here in Rochester. He is a syncope expert, and he's going to talk us through this. We're going to first go through your questions real quick, and you can see how they do and see where you can emphasize. So, a 75-year-old male with one brief episode of unresponsiveness when he was watching TV at night. That happens to me all the time. His wife noted that he did not respond to her calling for approximately 10 to 20 seconds. He was unable to recall the event after he regained consciousness. His past history is significant for coronary disease and hypertension. He had an echo 2 months ago with an EF of 40 and an anterior wall akinesis. He's on a atenolol 50, aspirin 81. His physical examination was noted for low-grade holosystolic murmur along the left sternal border. There was no orthostatic hypotension. Carotid sinus massage induced a 2.5-second pause without any symptoms. This is his ECG. Yeah, what would you do next? Exercise thallium, EP testing, ICD implantation, loop recorder, or continued observation? You have a learning opportunity. Okay, the next question is a 45-year-old man with 10 to 15 lifetime episodes of syncope, usually after discomfort, GI or venipuncture, but not orthostatic stress. He had loss of consciousness after awakening in the middle of the night. He experienced a second episode in the ER when getting up from the bed. His EKG, cardiac echo, and prolonged monitoring were negative. So recurrent syncope. Here's his response to head-up tilt testing.
Since this is for cardiology board review, just ignore the bottom panel there. That's the cerebral blood flow velocity. Just focus on the top two tracings. Blood pressure in the middle, and the heart rate on top.
So go ahead and put the question up so that while they're looking at that. What is the most appropriate therapeutic recommendation? Atenolol to 50, Paxil at 40, a pacemaker with rate drop feature, midodrine, or propranolol? Excellent. All right. A 59-year-old man is referred to by his primary internist for evaluation of coronary disease, 2 prior MIs 2 years ago. He's had triple vessel bypass 1 year ago. He's had no chest pain during daily activities. He's on appropriate medications. His echo shows an EF of 28% with moderate mitral regurgitation and anterior wall abnormality. On an exercise test, he went 7 minutes on the Bruce, no chest pain. There's evidence of anterior and lateral scar, no reversible changes. What would you recommend? Coronary angiogram, continued observation, ICD, follow-up in 1 to 2 months, consider ICD if the EF remains less than 30, or prophylactic amio. Okay. A 67-year-old woman presented with chest pain and a STEMI 3 days ago, had coronary intervention with 2 stents in the LAD. She's had no recurrent chest pain and she's stable. She has frequent PVCs and a run of non-sustained ventricular tachycardia that was not symptomatic. Her echo EF is 30 with severe regional wall motion abnormalities. What would you recommend? An angiogram, continued observation, ICD, optimized medical therapy and arrange follow-up in 2 months, or start her on amiodarone. Most selected number 4. All right, a 67-year-old man with a VF arrest, prior history of coronary disease and CABG, had acute onset of chest pressure with ST elevation in V2 through V4. On the way to the cath lab, he arrested. He was resuscitated. He had total occlusion of the vein graft of the LAD. The native vessel was occluded. Angioplasty of the vein graft was not successful. He has frequent non-sustained VT, noted post-PTCA attempt. That was treated with amiodarone. A viability study showed less than 5% hibernated myocardium. 45% of the ventricle is scarred. His EF is 32 at day 4, and he is ready for hospital dismissal. What would you recommend? Implanting a single chamber ICD before dismissal, implanting a dual chamber ICD before dismissal, continuing amio and follow up in 6 weeks with an echo and a Holter, or continue the amio, prescribe a wearable defibrillator, and follow up in 6 weeks with an echo and a Holter. Okay.
Very good.
Win,
Right.
tell them what they need to know.
Okay. Thank you, Steve. It is great to see quite a few of friends and Mayo alumni in the audience. And my task today is to take you through the topic of syncope and sudden cardiac death prevention. And there are 3 objectives I'm hoping to accomplish. And also from the answers that you provided to the questions that I drafted at the beginning of this presentation, it seems that I think your knowledge base when it comes to sudden death prevention, whether it is for primary or secondary prevention, everybody is pretty good. And syncope, as I heard from Dr. Ackerman for the past hour, the decision about what to do when a person presents with syncope is a very tough one. The reason is that half of the time it is really the person's clinical presentation, and whether that the presentation is more suggestive of a benign nature as compared to those presentations that may be some kind of a signal of a higher risk, and of course that the triage and subsequent evaluation that would be different. So first, that my job is to describe appropriate testing and manage patients with syncope. And second is to describe the testing and management of patients after out-of-hospital cardiac arrest. So this is the space or the arena for secondary sudden cardiac death prevention. And third, that the indication for ICD implantation and select the appropriate patients for this intervention. And this is the topic for primary prevention. So let's take a look at syncope. And when we see patients with syncope, that immediately that after history and physical, the key is that what do the physical and history that would suggest one of the 4 categories of potential causes of syncope. Really, there are only 4 large categories. Reflex syncope and neurally mediated or vasovagal syncope is the most common cause, and orthostatic related syncope, then cardiac arrhythmias and structural heart disease. Now, you will see quite a number of questions that with syncope embedded that in the question. The question is always that is the patient that presenting with syncope that with or without underlying heart disease. You will get a couple questions, isolated questions that with how to deal with patients with vasovagal syncope. But in patients that who present with symptoms and characteristics that's suggestive of a higher risk, and how do you triage and manage these patients is really the key. So let's take a look at the test indications for tests and the interpretation of results of the 3 main categories of evaluation that we have for patients with syncope: the tilt table testing, electrophysiologic testing, and implantable loop recorder. Here is the latest recommendations for indication for tilt table testing. Quite a few years ago, when tilt table testing was quite popular and widely used, and today we understand that most times history that would tell us a lot, that tilt table testing becomes, as you see, that in the most recent recommendations, becoming a class 2 indication, means that if it's 2A, that means the benefit is likely greater than risk. If it is a 2B indication, that means that the benefit may be that greater than risk. And class 1 indication, that means that the benefits is clearly greater than risk. So as you see that if we're just looking at that this particular table about tilt table testing, the tilt table testing is becoming a second class 2 indication, and provided that if these patients that have suspected vasovagal syncope or recurrent episodes of syncope, but you still suspect vasovagal syncope, but there is not, you don't have quite the confidence to make the diagnosis, then consideration of the tilt table testing that can be made. And tilt table, looking at here, tilt table testing is a reasonable consideration to distinguish convulsive syncope from epilepsy, to establish a diagnosis of pseudosyncope, functional syncope, and in patients with suspect vasovagal syncope, again, that without diagnostic features. And so tilt table testing that can be considered and may be useful in patients that you suspect to have vasovagal syncope, but you don't quite have the confidence of making the diagnosis, or in patients with recurrent syncope, and when tilt table testing may confirm your suspicion when a person has recurrent syncope. The last item here is also very important. Do not use tilt table testing to predict the response of drug therapy for vasovagal syncope because of the lack of reproducibility in this setting. So there is no indication for tilt table testing to test the response or the effectiveness of drug therapy for patients with vasovagal syncope. You saw a similar tracing, and to the typical example that should there be a tracing on the boards that you will see, there is going to be a continuous recording of heart rate, and as reflected over here, and while blood pressure in a continuous recording with systolic and diastolic pressure. After the patient is tilted, and often that there may be some fluctuation of the heart rate, but when the event occurs, that with a vasovagal response, there is a decrease in blood pressure, and at times there may or may not be that a drop of the heart rate, and this is very typical of a vasovagal response. And so that learn and be familiar with this type of tracing, and usually that I do not anticipate any kind of trick questions when it comes to showing you and interpreting a tilt table testing result. But it is really important to differentiate a typical vasovagal response during tilt table testing, that differentiating it in a person with autonomic neuropathy and orthostatic hypotension. This is, of course, a very severe case, but if there should be any recordings on the test that to differentiate these conditions, they will give you a very, very typical case of autonomic neuropathy. So what you see here is the heart rate on top. There is hardly any change of the heart rate that at 60 beats per minute. And while tilt, that the systolic pressure and diastolic pressure immediately after the patient was tilted, that there was dramatic drop of the blood pressure until the person was tilted back to the supine position. So recognizing tilt-induced changes typical for vasovagal response, at the same time differentiating in patients with a classic orthostatic hypotension in the setting of autonomic neuropathy. So that how about electrophysiologic testing in patients presenting with syncope? Class 1 indications, these are the patients with evidence of underlying cardiac abnormalities. In a patient that presenting with syncope, of course, they're going to give you the history of fairly typical for cardiogenic presentation, meaning that the spell occurred in the sitting position, in the supine position, without warning, or that with palpitations. Those are the characteristics that will lead to the thinking of a cardiogenic syncope, but you would consider a electrophysiologic testing if a person presenting with syncope suggestive of a cardiogenic etiology in the presence of a bundle branch block on the electrocardiogram, and especially in older patients, you suspect that patient may have intermittent conduction system disease. Patients with history of coronary artery disease with prior myocardial infarction with ejection fraction better than 35%. Because today, we will review the primary and secondary prevention that for certain cardiac death, among those patients, if they have had myocardial infarction with injury and ejection fraction less than 35%, today that there is really no EP study that's needed in a patient as such with syncope because device therapy with ICD that would be indicated. So in patients with coronary disease with prior myocardial infarction with ejection fraction greater than 35%, consider that electrophysiologic study. And of course, those patients that with palpitations, with suspect intermittent cardiac arrhythmias, especially if the presentation is dramatic, while the frequency of these spells is infrequent, then you would consider electrophysiologic study. Class 2 indication that to evaluate document arrhythmia mechanism. Today, that most times the reason why this becomes a class 2 is that most times should there be an arrhythmogenic etiology with documented documented spontaneous arrhythmias, and these patients most times that would either undergo ablative therapy or undergo through a device therapy, and a diagnostic EP study that in this setting is becoming less and less. High-risk occupations exclude the cardiac cause of syncope. That's always a consideration. And class 3, again, remember that in patients that with normal ECG, without heart disease, and there is no history to suggest a cardiogenic syncope, there is no indication for electrophysiologic testing. You have seen, I saw that Paul showed a couple of tracings and of intracardiac recordings, and this is the recording. I would anticipate that for cardiology boards, this is expected everybody to at least recognize the recordings of the His bundle. And what I show here is that usually that when we do an electrophysiologic study, a catheter is positioned in the right ventricle, and what you see on top is the surface lead electrocardiogram. On the bottom is the intracardiac recording. You see a local ventricular electrocardiogram. On the His bundle, you see that this particular catheter has 4 poles. Each of these local recordings is a bipolar recording. So this one is the distal bipolar, and this one is the middle bipole, and the proximal one is over here. So this His bundle His catheter is positioned near the His bundle. What you will see there is a ventricular recording, a His bundle recording, and the atrial recording. As the pole gets to the atrial side, you see a bigger atrial recording. You still see a His bundle recording and a ventricular recording. With the proximal bipole, and if indeed it's moving out of the His bundle location, sometimes we lose the His bundle recording, but you see a bigger A recording and the ventricular recording. And there is a diagnostic catheter here is positioned in the high right atrium, and what you see is a local atrial electrocardiogram. Occasionally, because the ventricular voltage, because the mass is so much larger, that you may see this, we call it far field ventricular electrocardiogram. So that the AH interval reflecting the conduction through the AV node most of the time, it can be quite variable because of the fluctuating vagal tone. It's very much dependent on the awake state of the patient. and also depends on catecholamines and all of those. But his bundle, that recording, and the his bundle conduction time should be fairly fixed between 40 to 55 milliseconds. So keep those numbers in mind, because then, of course, they be abnormal recordings. And when you see a recording like this, and for those of you who are not electrophysiologists, don't really get nerved up, because as always, that these recordings on top, you will get a few channels of the surface lead electrocardiogram. Always pay attention to the PR interval and the presence or absence of bundle branch block. That's for everybody. And we all can read electrocardiograms. So if you look at this particular electrocardiogram, and even though that on the test you will have calipers and such, but this person has a first-degree AV block and left bundle branch block. Then on the intracardiac recordings, you will see the high RA recording with an A and far field V, his bundle recording, and you see AHV, AHV. Now these numbers are given to you, HV interval of 80 milliseconds. So in this patient, the patient that is presenting with a syncopal event that's suggestive of a cardiogenic nature by history, and EP study shows a HV of interval of 80 milliseconds. There is significant conduction system disease in the absence of any other identifiable causes of syncope. Indication for pacing is well established. So that know your normal numbers, know how to identify these simple recordings, especially his bundle recordings, and know the indication for electrophysiologic testing. This is for your reference, and I don't think that you're going to really need to get to this detail. I listed that what is considered to be abnormal when we do electrophysiologic study for sinus node dysfunction, and his Purkinje conduction, as I have already mentioned. And so you saw that recording from Dr. Friedman earlier, that was infrahisian block, that certainly would be abnormal. Of course, for syncope evaluation, that during the EP evaluation, if SVT is inducible, and so you want to make sure that this SVT induced in the laboratory that could explain the patient's spontaneous event of syncope. And sometimes that could be a challenge, because we always want to make sure that doing the EP study in a laboratory setting, what we are inducing in the laboratory really can explain the patient's clinical spontaneous event. And then ventricular tachycardia. And if a monomorphic ventricular tachycardia is inducible in the presence of structural heart disease, whether that is a patient with coronary disease with myocardial infarction in the past, or patients that with structural heart disease with scars and such, that monomorphic ventricular tachycardia is almost always clinical. It is not a false positive recording. But if the ventricular fibrillation or proarrhythmia, ventricular fibrillation or polymorphic ventricular tachycardia is inducible, and most times that this is not clinically, it's not very reproducible, then you always have to question the significance of inducible polymorphic VT or ventricular fibrillation in the laboratory. You heard the eloquent presentation from Dr. Ackerman, and I would put the perspective with regards to electrophysiologic evaluation in patients that with familial conditions. When it comes to diagnostic purposes in relevance with the electrophysiologic study, there is really no that role for electrophysiologic study for the diagnosis of long QT, Brugada, CPVT, hypertrophic cardiomyopathy, ARVD. The reason is that you already saw electrocardiogram, Holter monitors, and spontaneous that bidirectional block during exercise. Diagnoses are made by your recordings, not electrophysiologic study. And even for hypertrophic cardiomyopathy and ARVD, these are morphological abnormalities. These are not EP-induced diagnoses. But when it comes to risk stratification, to the most part, EP study for these conditions, there is minimal role, if any. You've heard that from Dr. Ackerman,
that about Brugada syndrome. And Brugada syndrome, it's controversy, but for the purpose of taking the boards, there is no indication for electrophysiologic study in an asymptomatic patients with Brugada ECG. And when it comes to ARVD, again, this is not entirely with consensus from all of the experts in the area. If a person with ARVD with frequent PVCs, asymptomatic, if you really are worried about potential risk for sudden cardiac death, sustained ventricular tachycardia, you could consider an electrophysiologic study for risk stratification. But otherwise, there is very minimum role for EP study in patients with familial conditions. How about the implantable, now injectable loop recorders? I show you the size of the initial device, and then the current injectable device of you. I think some of you have been ordering these or implanting these. It's a very straightforward procedure that you puncture a little incision on the skin, you push the device in, and it is done. It does not even require suturing. And down the road, a smaller device will be coming, and so it will keep on getting smaller. But the question always is where are we when it comes to using this device for clinical indications? And what I have here is really what we think that today, and with the practice, and while this was spelled out a few years back in 2009 from the ESC guidelines, but you will see that we will be updating the guideline, and we'll probably have some new indications. Today we are only talking about syncope. We're not talking about monitoring patients with cryptogenic stroke. So there's a whole new area for these injectable devices. So the injectable or implantable loop recorders in the context of syncope evaluation, patient with recurrent syncope of unknown etiology, absence of high risk for mortality or morbidity, an implantable loop recorder can be considered before electrophysiology study. So interpretation of this recommendation is very important in the absence of high risks. So if you really think in your clinical evaluation, this patient has a high risk for cardiogenic syncope, potentially impacting on prognosis, consider electrophysiologic study before implantable loop recorder. On the other hand, that if the person doesn't have the high risk and you are contemplating whether the diagnosis can be best established by recording a spontaneous event with an implantable recorder or taking a patient to the laboratory for EP study. Often, if the risk is not high for cardiogenic syncope, especially in patients with infrequent spells, implantable recorder would be indicated. And high-risk patients without a diagnosis after comprehensive evaluation. You have a history, you think the patient that is high risk, but doing your evaluation, including an EP study, you cannot reach a diagnosis consideration of an ALR. And the class 2 patients with reflex syncope with frequent recurrence and trauma before pacemakers considered for possible intermittent bradycardia. That's a class 2 indication. And this is a typical recording and from retrieved information from an implantable loop recorder, a spontaneous event with sinus arrest with several seconds of pause, correlating to syncope and class 1 indication for pacing therapy. And then when it comes to treatment for syncope, and when the diagnosis is established, treatment decision is quite straightforward. Bradycardia, pacemaker therapy, supraventricular tachycardia, ablation, drugs, what device, depending on what it is, ventricular tachycardia, ICD, drug, or ablation, orthostatic hypotension, well, depending upon the precise etiology. But reflex syncope or vasovagal syncope is really the challenge today, because simply there is not a very effective way of treating patients with vasovagal syncope. So what do we do and what is the guideline? So first, the class 1 indications here are conservative approach. So should you encounter a question with regard related to vasovagal syncope, always think that use conservative measures, making recommendations on the onset, whether that to reassure these patients, explain the risk of recurrence, and isometric that physical countermaneuvers that can be effective in some of these patients. Cardiac pacing would be reasonable to consider in a person who is somewhat older, here is 40 years of age, that with recurrent syncope and documented pauses, especially if syncope is associated with trauma. So there is a class 2 indication for pacing that in patients who have documented spontaneous pauses. And should you need to answer that if the question that only gives you the choice of medications, midodrine is the only drug from small studies, some mostly observation, couple very small randomized studies showing midodrine appears to be effective in patients who are refractory that in vasovagal syncope. And beta blocker, as of today, there is no indication for beta blocker therapy for vasovagal syncope. Let's take a look at secondary prevention that for sudden cardiac death, meaning that these are the patients that have had out-of-hospital cardiac arrest. Among patients who have had survived out-of-hospital cardiac arrest, about 3/4 of these patients have underlying ischemic heart disease, 20% with non-ischemic cardiomyopathy, about 5% with familial congenital conditions. Most times, cardiac arrest is related to ventricular tachycardia, ventricular fibrillation, a minority that is systole, and EMD, PEA, that is about 5%. Appropriate test selection, and this is really, I think, common sense, and everybody that follows these, and including electrocardiogram, baseline blood laboratories to ensure there are no transient electrolyte abnormalities that could be correctable, left ventricular function assessment with cardiac imaging, coronary angiography, especially in the older patient population that with suspicion of coronary artery disease, that is always recommended in patients after out-of-hospital cardiac arrest. Occasionally, we do not recommend the coronary angiogram for those patients who have clearly a documentation of long QT Brugada and with a primary arrhythmogenic event that in the younger patient population. Selected genetic testing, and Dr. Ackerman has gone over these, and EP study is rarely recommended or needed that after a cardiac arrest, because today that we have plenty of data to tell us that if indications are met, ICD is indicated and EP study is really unnecessary. So ICD therapy for secondary prevention after out-of-hospital cardiac arrest. The survivors of cardiac arrest due to ventricular fibrillation or unstable sustained ventricular tachycardia after evaluation to define the cause of the event and to exclude any complete reversible causes. I list that several of the reversible causes, so when there are questions about secondary prevention, making sure pay attention to the content of the question, whether any of the reversible causes that may be present that in this patient's presentation. Drug proarrhythmia, ablatable arrhythmias in normal heart in patients with pre-excitation with Parkinson-White syndrome presenting that with VF arrest, polymorphic ventricular tachycardia, ventricular fibrillation within 48 hours of myocardial infarction, and electrolyte abnormalities. Then also another indication is that if the patient has spontaneous ventricular tachycardia, whether that's hemodynamically stable or unstable, but if there is underlying structural heart disease, even though that their VT may be 150 beats per minute, the patient that is still awake and did not have syncope, but if there is underlying structural heart disease, ICD is indicated. I list class 3, this is important because if there should be any contraindications that you need to know as you read the questions. And that if the persons, this is very clinical, there's clinical judgment coming to this. If the patient's overall survival is less than 1 year with expected survival, and incessant VT or ventricular fibrillation, if a person has incessant ventricular arrhythmias, ICD is contraindicated because we don't really, you can't really put the ICD when the patient is continuously with incessant ventricular arrhythmias. Psychiatric illnesses, and as we go through the next indications for primary prevention, keeping in mind patients with class 4 heart failure symptom, there is no indication for standalone ICD, unless they are qualified for CRT or cardiac transplantation and a complete reversible cause that would be a contraindication for ICD implantation. Going on to objective number 3, primary prevention. And primary prevention, these are the patients with underlying heart disease who are at higher risk of sudden cardiac event, but they have not had an event. Majority of these patients have ischemic heart disease, non-ischemic cardiomyopathy, and familial conditions. Here is a very simple table, essentially that summarizes that the current practice guidelines indications for ICD for patients that with underlying disease. So first, that is remember that ejection fraction needs to be less than or equal to 35%. So for patients that with ejection fraction of less than 35% and with a New York Heart functional class of 2 or 3. Doesn't matter if you have ischemic heart disease or non-ischemic heart disease, there is class 1 indication for ICD implantation for primary sudden cardiac death prevention. Class 4 patients, stand-alone ICD, there is no indication. A little bit tricky here, but it's fine details. For class 1 patients, because of trials and how many trials and what kind of trials that we won't go into the details, for ischemic patients with class 1, so in other words, there is no that significant symptoms that are related to their underlying heart disease. If they have ischemic heart cardiomyopathy, ejection fraction is less than 30%, there is class 1 indication. But if you have a class 1 patient that with non-ischemic cardiomyopathy, then this becomes a class 2B. So just remember class 2, class 3 patients that with the ejection fraction of 35% indication for pacing is met. But here is really the key, and you will be tested on this. Timing to myocardial infarction, that should be greater than 40 days. So within 40 days after a documented myocardial infarction, there is no indication that for ICD implantation for primary prevention. And timing to revascularization. Should there be coronary artery bypass surgery or PTCA with stent placement, that again, there is no indication for ICD and until after 90 days when you re-evaluate these patients and if the ejection fraction remains to be below 35%. The topic for discussion is wearable defibrillator. And today, that officially, there is no recommendation, there is no guidelines, there is a consensus statement, currently is under review, hasn't been published from the Heart Rhythm Society. And so even though clinically that we always believe that in these two groups of patients, if we really worry about their sudden cardiac event within 40 days of myocardial infarction or within 90 days of coronary intervention, intervention, that we may prescribe that a wearable defibrillator for these patients. But today, that when it comes to practice guidelines, there is none. And what we know is that wearable defibrillator is effective that in terminating ventricular arrhythmias, but inappropriate shocks are present, while that up to date, all of the studies have not shown survival benefit in this type of, in these two patient populations bridging to the permanent ICD implantation. So I would say that for the test purposes as of today, that answer for wearable defibrillator that should not be included in your thinking process, although clinical practice that we have done this in some of these patients. So finally, that pearls. I would summarize that my thoughts when with regards to syncope. Pay attention to the clinical presentation, differentiating a more benign presentation from a cardiogenic presentation, looking for factors differentiating cardiac versus non-cardiac causes of syncope. Unexplained syncope is a risk factor for sudden death in familial conditions, and that's where Dr. Ackerman emphasized that the nature of the presentation for those familial conditions. No indications and contraindications for electrophysiologic testing, implantable recorders and tilt table testing, and know the interpretation of test results and tracing. And a conservative approach to vasovagal syncope. That's kind of the rule of thumb that for those patients. Should you need to really the choice is for pharmacological therapy. So secondary prevention. So I listed here that ICD is indicated except for these reversible conditions. So kind of look out for whether this type of information is in the question. And then for the primary prevention, that essentially summarized that table that I had for you, that listing the indications that for ischemic heart disease, non-ischemic cardiomyopathy, New York functional class. Standalone ICD is not indicated in patients with class 4 heart failure. And no ICD less than 40 days after myocardial infarction, and no ICD less than 90 days after coronary intervention. So I listed key references, and all of these are either guidelines or consensus statement that for the review that we just went through. And thank you for your attention. And then we'll go on to questions. Okay. So we have about 10 minutes.
So let me ask one question that about 3 people have just submitted, and that is post-MI, 90 days versus 40 days to wait. There was some confusion that one of the lecturers talked about that.
So yes, that's a very good question. So the 40 days and 90 days is whether that you have, if the patient has undergone coronary intervention. So if a person has had coronary intervention, that without myocardial infarction, with a compromised ejection fraction, coronary intervention is defined by either coronary artery bypass graft or stent placement. Then you need to wait for 90 days. You see, how did this come about? It was quite arbitrary. As a matter of fact, it had to go to the Department of Justice when the data were reviewed, because there was, a lot of these studies really did not have the 90 days, but they were that subpopulation analysis showing that these patients, once they have had interventions, that there is in some of these patients, there is increase of the ejection fraction. So the answer to the question is that if a person has had coronary intervention, CABG or stent placement, with or without myocardial infarction, no ICD implantation within 90 days. If a person who has had a myocardial infarction, that if you have not intervened, only pharmacological therapy, that you wait for 40 days, because there were a couple of trials showing that there was no ICD benefit on survival for those patients. But if a person had acute coronary syndrome with stent placement, 90 days.
All right, thank you.
Okay.
All right, let's go back through these questions because they're good.
Okay.
So this is the... go ahead. 75-year-old guy with unresponsiveness while watching TV. He didn't respond to his wife for a few seconds. He was able to recall the event after he regained consciousness. He's got known coronary disease and hypertension, an EF of 40% with an anterior wall motion abnormality. He's on a atenolol 50 and aspirin 81. He's got a low-grade holosystolic murmur along the left sternal border, no orthostatic hypotension. His carotid sinus massage induced a 2.5-second pause without symptoms. This is his ECG. And what would you do next? Exercise thallium, EP testing, place a box, place a loop recorder, or observation.
That's better. And so here is a patient that in this question, the information is given to you, he had a syncopal event. They're not going to tell you, the question is going to be just how it is stated. It's not that he dozed off while watching TV. And he had
sure he didn't just fall asleep and was ignoring his wife?
That's right.
Okay.
10 to 20 seconds, not responsive. So the information suggests that this is a cardiogenic event. But the additional information is important. This patient had a history of coronary disease ejection fraction of 40%. So this patient that is at a higher risk for cardiogenic event, he has abnormal laboratory findings and electrophysiology that study that is indicated. And so that I put over here, the patient has coronary disease, prior myocardial infarction. Just syncope alone, you don't have an indication for ICD implantation because ejection fraction is better than 35%, but yet his risk for a cardiac cause of syncope is increased, and so there is strong indication for electrophysiologic testing. So let's go on the second question.
45-year-old male with 10 to 15 recurrent episodes of syncope, usually with discomfort but not orthostatic. He had loss of consciousness after awakening in the middle of the night. He experienced a second episode in the ER after getting up from bed. His EKG, echo, and monitoring were negative. A head-up tilt test was done, and we're supposed to ignore the cerebral blood flow. And so what are the most appropriate therapeutic recommendations? Atenolol 50, Paxil 40, dual-chamber pacemaker with rate drop, midodrine, or propranolol?
That's great.
Excellent.
So this question is it's fairly straightforward. They're not asking you for any other interventions, but if you were going to select the drug, there's really today, even though the data are fairly soft, but it's really the only drug has been shown in some of the observational studies that have been effective, the randomized studies. So midodrine may be indicated in patients with vasovagal syncope.
All right, a 59-year-old man is referred to you by his primary internist for evaluation of coronary disease, 2 prior MIs, triple vessel bypass a year ago. He has no chest pain. He's on those meds. He's got an EF of 28% with MR and wall motion abnormalities. He can exercise for 7 minutes with no chest pain. He's got scar and no ischemia. Would you recommend an angiogram, observation, an ICD, follow-up in a couple of months to consider an ICD if his EF is still below 30, or give him amiodarone? Good.
Great. So he goes into this category here.
67-year-old woman presented with chest pain and a STEMI 3 days ago, had PTCA and stenting of her LAD, no recurrent chest pain. She's hemodynamically stable but had a non-sustained 7-beat run. She was not symptomatic. Her EF is 30 with the wall motion abnormalities. Should we do an angiogram on her? Mm-hmm. Observe, ICD, arrange for follow-up in 3 months, or start her on amiodarone?
All right. Here.
Yeah.
I think we have nailed this one down. Okay, now let's, so I actually put a supplemental slide here, is really showing the trials that showed within 40 days after acute myocardial infarction, there was no survival benefit when patients were randomized to ICD versus no ICD. And then that, so infarction alone without the intervention, 40 days, but while if there should be any intervention, 90 days.
Yep. All right, 67-year-old man, again with coronary disease and prior bypass surgery, was brought in for acute onset STEMI. On the way to the cath lab, he had VF, resuscitated. His vein graft adenoid vessel were closed. He had angioplasty of his vein graft, but that did not work. He has frequent non-sustained VT post-intervention attempt. He was started on amiodarone. He has some less than 5% hibernating myocardium, 45% scar. His echo EF is 32%, and he's ready to go home otherwise. Should we give him a dual chamber ICD, or sorry, a single chamber ICD, a dual chamber ICD, amiodarone with follow-up echo in Holter in 6 weeks, or amiodarone, a wearable defibrillator, and follow-up in 6 weeks with echo and Holter?
Right, so I think majority of you would practice in this way, and including myself, that I may consider that this option. But today, there is no recommendation or data to really support this practice. And so that I actually put number 3 as the right answer for the board purposes.
So for board purposes, because there's no indication for a vest, you're going to just do the follow-up in 6 weeks. But
Correct.
in real life, you're probably using a wearable defibrillator while you're doing that.
Next year, when we review this topic, we may have a recommendation.
Okay.